Good afternoon, everyone, and welcome to Grand Rounds today. Today I have the pleasure of introducing Dr. David Demarest. Dr. Demarest received his undergraduate degree in psychology at the University of Virginia. He then received a master's in clinical psychology at Virginia Commonwealth and his PhD in clinical psychology at the University of West Virginia, He then completed postdoctoral fellowship in rehabilitation and neuropsychology at the University of Missouri, and he has very kindly accepted our invitation today to give us an update on attention deficit hyperactivity disorder and autism spectrum disorder. And please join me in welcoming Dr. Demarest.
Thank you very much for the kind introduction. Good morning, everybody. Thanks for having me. I appreciate it very much. I've got a lot of material to cover. I'm going to try and leave about 10 minutes for questions here. I prefer to do these in person, but the world is the way that the world is. Feel free to contact me if you want some other sort of education for another group that you're a part of. I like being able to do this. Thanks for the referrals. I get a lot of referrals from you guys up that way, a number of the physicians. I am both a pediatric and other ages neuropsychologist. My master's degree was in child clinical psychology. Love kids and thought I'd want to work only with kids. So I have a kid background, and then I worked for 9 years, went back and got the doctorate, and I worked with all ages. So I adhered on with life. I have an outpatient. We have an outpatient program. So you may be familiar on with life. We work on an inpatient basis and outpatient with folks with traumatic acquired brain injuries, strokes, and motor vehicle accidents and so forth. But I'm being a pediatric neuropsychologist. I don't know of another specific pediatric neuropsychologist in Iowa, so I get a lot of kids. More of my evaluation work these days is with kids. Unfortunately, of course, kids can also have traumatic brain injury and stroke and so forth. But most of the kids that I see, it's the congenital conditions, ADHD, autism spectrum disorder, the specific learning disorders. We used to use the term learning disability, the DSM-5 term, and now is learning disorder, and then intellectual disability. So I have chosen to include a lot of material in the slides. Some of them I'm going to go through pretty quickly, but my style in doing presentations is to try and give you stuff that's going to be helpful that you can reference back. I'll try and hit some points that I hope are highlights as we go along, and we'll save 10 minutes for questions at the end. ADHD is a behavioral diagnosis. There are tests that are more or less sensitive to attentional dysfunction, but that behavioral assessment is critical from parents, from teachers, from your observation of the kids. I recognize I'm presenting to a wide range of professionals here, so if some things are a little basic, pardon me, and some things are a little bit advanced, pardon me for that as well. You want to try and seek a balance here. If you look at the incidence of diagnosis of ADHD, it goes 3 years old, 4-year-olds, 5-year-olds, and then 6 years old / first grade, the incident rate goes way up. And it's not because I tell parents, not because kids' brains change, when they're 6 years old that differently, but it's the structure in place. And so teachers are often the first ones to kind of note problems in these areas. So you may be familiar with the Vanderbilt scales, the Connor scales. I think particularly for complex cases, I know physicians, pediatricians know ADHD and see a lot of it. But you may consider, especially for something that's more complex, somebody like me to kind of look at things for you. If you're not familiar with the Vanderbilt, it's a rating scale. I'll leave this up for a second. I use the Connors here. Psychologists are a little more likely to use the Connors. It's a little more in-depth, the Connors. And I will get parent ratings, teacher ratings, as you guys often will, if you're a care practitioner. And you can also get self-rating on the Connors, which, especially for older kids, becomes more relevant because the dictum that kids, quote unquote, outgrow, that's not the best word to use, but ADHD, there's validity to that. And how much of that is the maturation of the brain, how much of it has coping mechanisms. We don't know. I have a nephew who had a milder case of ADHD, and he's a bright kid, talks about developing his coping strategies over the course of especially 12, 13, 14 years old. And so there's the Connors. The Diagnostic and Statistical Manual for Mental Disorders. When I do an evaluation for ADHD or autism, I always do a parent interview first. Not all professionals like me do that. I think you should. It's kind of a duh thing to me before you see a kid that you spend an in-depth amount of time. And I go through these specifically with parents, or if I do happen to be interviewing a teacher or somebody else, I will go through these criteria specifically because these are the criteria that one uses to make these diagnoses. Some of the things that I point out to parents when I go through these specifically with them. Well, let me tell you that I always get if there's more than one person, mom and dad, for example, I'll always do a mom list and a dad list, or a person A and a person B list, because people don't always see things the same way. You know, I'm not going to go into the issues too much today of the stigma of all this. We'll talk about medicines a bit as we go along. But this is hard. This is a hard, I have people getting upset and crying in my office when we talk just even about the possibility of this diagnosis. I try and, you know, normalize the best one can having a problem for them. But these are difficult things, so there's disagreement. But some things to point out is that these things can't just be a manifestation of oppositional behavior. They can't be because a child doesn't understand. And the word often is in every one of these. So these are the inattention criteria. I'll forward and come back to this, and then we've got the hyperactivity and impulsivity criteria. And so you can read those. I'm not going to go through every single one, but these are the things that are more likely to be seen. These are the things that the factor analysis has shown is more likely to demonstrate that a child has an attention deficit hyperactivity disorder. Particularly that word often. Every kid's inattentive. Every kid is fidgety and restless sometimes. All of this is a question of degree. And so compared to other children of that age, are you seeing these things? Then we go on to the hyperactivity and impulsivity. I'll leave this up for just a second. A lot of these are common sense sort of things. And again, you know, if you ask, does a child ever do any of these? Well, every child's going to meet every criteria for both the inattentive and then the hyperactivity impulsivity criteria. But it's a question, again, of degree with these things. And ADHD runs on a continuum. We'll come back to that here. In addition, you've got to see something before age 12 years. We'll talk about adult ADHD just a bit. I have a colleague here, Dr. Allison Logeman, who's an expert in adult ADHD, and we come back to that. It's got to be seen in several symptoms, excuse me, in several settings. It's got to interfere in some fashion in life. And this is important, we'll talk about this today, it can't be explained by another mental disorder. And again, that's where I come in. I get kids and the referral from the physician says there's mood stuff there's going on, there's anxiety stuff, there's behavior stuff. You know, if you have an ADHD, a true ADHD, you're going to have anxiety problems of some kind. You're going to have behavioral difficulties of some kind, of some degree. Some kids more, some kids less. But, you know, kids with ADHD, especially untreated, are more likely to get in trouble. If they're perceptive at all, they'll see that they're different. People will point out that they're different. They're treated differently in school than at home, and that can have psychological difficulties. So which came first, the chicken or the egg, becomes a very relevant sort of issue in making these diagnoses. This is from the Diagnostic and Statistical Manual. I think my next slide, let me go to that for just a second, also asks how clean are these types. So we'll talk about that. The most common type is the combined type. You have the inattentive problems, attention, focus, concentration, and you have the hyperactivity, impulsivity problems. You may be familiar with the ADD term, attention deficit disorder, without the H, without the hyperactivity. I almost always see, even in a predominantly inattentive type, so I encourage you to be aware of this, some degree, when I have a kid in my office, of fidgetiness, restlessness, especially as time goes on. I spend a lot of time with a kid. We take breaks. Sometimes if you have an ADHD, you can hang in there for a while. Then it just gets to be too much. I have students that have said to me after 45 minutes with a kid where they were calm and quiet and attending and focusing, and then we come back in after a break and the student says, holy cow, you know, is this the same kid? Because they can hang in there for a while, especially bright kids, or compliant kids, which is an important point. But they can't hang in there forever if you have a true ADHD, biological condition that affects your, it's not a won't, it's a can't. There can be elements of won'ts too. You may have heard the term oppositional defiant disorder. Kids with ADHD get diagnosed with an oppositional defiant disorder, which just means you have a degree of oppositionality and defiance greater than most your age. So the more common one is that you have the combined inattention and hyperactivity. Less common is a predominantly inattentive type. And there are some kids, but not many, who have the hyperactivity, impulsivity, but don't show the attentional, I should say, superficially. When you get in there and you do some digging, you'll find out with those kids that there are plenty of attentional difficulties. Now, the symptoms can change over time. How much of that is brain maturation? How much of that is coping? How much of this condition is a brain condition? Lots we don't know. We'll come back to that. Again, it runs on a continuum, for sure, which the literature supports. It is elevated in the first degree biological relatives. So there's some heritability, and the DSM uses the term substantial for that. There's some figures. Actually, interestingly, you know, the figures have gone up. There's more and more diagnosis. There's more and more misdiagnosis of this for a number of reasons. There are people out there that may not know how to make this diagnosis. Well, the most common reason that people get misdiagnosed with an ADHD is because they have behavioral difficulties. So they look like they're not attending, they look like they're hyperactive, but when you do a more formal analysis, you don't find that they meet criteria. Rather, they have behavioral difficulties that explain the problems. So again, interestingly, if you look at the DSM-5 when it came out, which was 2013, I believe, that was 5%. And then CDC has it at 7.8% in 2003. And as of 2011, it's up to 11%. So the numbers, as with autism, increase. Some of that's greater awareness, probably, of this. Boys are much more likely than girls to be diagnosed. They're much more likely to have the hyperactive, impulsive type, or the combination type. But again, girls aren't without some degree of restlessness or fidgetiness. You know, and it's an important point. There are differences between males and females, and some of those may be biological, and some of those are certainly sociocultural. Girls are more likely on a continuum than boys to be compliant, to want to please, to, I would argue, be socially skilled. And so it goes unrecognized. It may go unrecognized in girls. I'm more likely to see a 12-year-old girl for a later assessment compared to a 6, 7, 8-year-old than I am a 12-year-old boy. But there's plenty of 12-year-old girls that I evaluate where it's clear that there is an attention deficit disorder. I had a set of parents in here last week who found the evaluation very affirming because they said we've kind of known this for a long time, but other people sort of poo-pooed it for them. And so there are differences in gender presentation. We've talked a little bit about the comorbidities here. I always assess intellectual functioning. I always assess academic achievement functioning. I always assess memory and learning because those things are sensitive to somebody having an attentional difficulty. I also want to see if a kid's just bouncing off the walls in my office, obviously, hyperactive. But even when a kid doesn't have obvious intellectual or academic achievement problems, I do those because they're sensitive. I'll give you a great example in a second here. They're sensitive to attentional dysfunction. And it's not uncommon for kids with ADHD whose brains are organized differently to have learning problems, to have a learning disorder potentially even. Sometimes we know that when we do an evaluation of a kid. But here's the example I was going to share with you. This is an older kid, 13 or so, a boy, 13 or so, a milder case of ADHD. And I read him story math problems, not because there was anything wrong with his math. Out of 14 problems, not once, not twice, 7 times, looking right at me, appearing to pay attention. Immediately when I got done reading the problem, his response was, huh? Right on by. Not once, not twice. That's a dramatic example, but that's not a normal. I don't like the word normal. What's normal? That's not a typical sort of thing. And that's an example of using a variety of measures to kind of get at this stuff. Important point. We have folks down the hall here at On With Life, adults who've had a traumatic brain injury, who didn't have ADHD as a child, no concern about it as an adult, but they look like they have ADHD now. Any neurological problem has the potential to affect one's ability to focus, concentrate, and pay attention. I have a lot of kids that I evaluate where our determination when we're done, I say we because I always think of this as me and the parents or caretakers working together, where when we get done, we find that they have attentional difficulties, but it's related to one of the medical problems that they have or medical concerns that have been brought up, that it's not a stereotypic ADHD. And there's patterns that I'll look for to help me kind of figure that out. An implication of that, it's important to assess that the best you can or to have a professional that knows this help you. But an implication of that has to do with the medicine issue. Some of our folks here at On With Life with those kinds of attentional difficulties will respond to a psychostimulant or stimulant-like medicine, but many won't, and sometimes it'll make it worse. The irony is that those meds, stimulant medicine, helps for a true ADHD, but keep that in mind. You can have attentional problems for lots of reasons that can make you look like you have a true ADHD, and it's not an ADHD. You have ADHD because, it's like asking why were you born left-handed? Ultimately, we don't know. Discussion of theory only goes so far. So let's move into the behavioral and environmental strategies that we know are helpful. And let's look at medicine. Talk more about medicine here in a bit. Look at we'll talk about this a little bit later. The American Academy of Pediatrics has a new set of guidelines out that's super helpful. You guys know the medicines better than I do. I'm not a physician. I always refer people back, obviously, to their physician for consideration of medication. But, unfortunately, if you have ADHD, you do, and that's the way your brain is organized. There's no biological marker that's diagnostic for it. We know a few things. Children with ADHD have increased slow wave EEGs, reduced total brain volume on an MRI. There's some delay in posterior to anterior cortical maturation. Before 6, the AAP is a little more hesitant. They don't say don't prescribe medicines at all. I'm a little more hesitant. They say let's do the behavior management, environmental behavioral stuff first. And then let's start looking at 6 years old for both the behavioral, environmental things, working with parents, parent training if that's important, especially as to behavior management. You're going to have behavior problems if you have ADHD, and it's not uncommon for parents to need some help. in figuring out how to manage that. Now, first, if you have an ADHD, let's treat the ADHD, I tell parents, and then let's see how much improvement. I've had parents say, oh my goodness, the behavior is 95% improved since we started the medication. Schools should be involved, etc. I can do another presentation sometime, and we'll go through all this. It's got lots on meds. Look this up. It's new. The latest AAP guidelines are here, and they just came out 2 years ago. The latest, you'll see later, the latest practice guidelines for autism spectrum disorder just came out last year. So this is chock full of phenomenal stuff and much more relevant if you're a medical practitioner, much more relevant to you as a medical practitioner as well. It covers the stuff we've covered, covers behavioral interventions, but covers the medicine stuff quite a bit. Oh, gosh, you know, pandemics affected everything. If you have trouble concentrating, focusing, and paying attention in a structured school setting, you may have trouble outside of it. On the other hand, if you're now at home and you have a parent overseeing your computer work, your online work, and you're one-to-one, and the parent is seeing that you're struggling, then it can be better for some kids. It's difficult on the relationship that parents have with kids. I'm glad we're getting kids back in school for lots of reasons. Parents are referring more because they're seeing the difficulties. So I see, again, younger ages often, 6, 7, 8, 9, where the parents are saying in the last year and a half since the pandemic's hit, holy cow, we're really seeing a problem in this now that we have them at home. Stimulants and non-stimulants, you know, this is, what's the last medicine you want to give a kid that's bouncing off the walls is a stimulant or stimulant-like med. It may change levels of dopamine. I can talk theory a little bit with you. You know, the reticular activating system helps us stay alert and awake and sort out stimuli, and it may not work as well in ADHD. And the stimulant, ironically, may help that part of your brain work better, such that you then can filter out and attend and focus. But ultimately, we're still doing to research it. You can't find a biological marker again for ADHD. 3 non-stimulants approved by the FDA, especially if kids don't tolerate a stimulant well. You know, an important point here is that if you have the comorbid anxiety problem, a medicine that's going to help for one thing can make another thing worse, as you know. So a stimulant can alter anxiety presentation. Physicians are experts in that. And it's not just medicine. It's all the environmental things. I always have a sheet. I think I have a copy of that here, maybe later, that I give to parents. On the other hand, I tell them it's not like you can't go onto the internet these days and find a lot of things if you just type in how do you help a kid with ADHD at home and school. So here, I think this is it. I always give parents this list. These are important things. Again, I'm moving pretty quickly, I know, but we've got an hour to cover everything you ever wanted to know about ADHD and autism. If you want me to present to your specific group sometime in a webinar, glad to do that. Routine, 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 structure, structure, structure is our friend. Manage distractions, limit choices. I had a kid a month ago whose parents said, when I give him toys at the end, get a couple toys out of the toy bag when I'm done with you. And they said, pick a couple toys out for him. Do not give him choices or you have them in your office for another 20 minutes. Be clear and specific. Plan. Use goals, praise, discipline effectively. Easier said than done. My son, I have a son, he did not have ADHD. I don't know from personal experience. I know professionally how difficult it is to parent a child who has autism or ADHD. So I say that humbly, but learn how to do that because it's especially important. I'm going to real briefly touch, I don't claim to be an adult ADHD. It's controversial for many. I'm not saying there isn't adult ADHD. There is, especially if you have ADHD as a child. it may continue. There's some substantial enough portion of people that it continues into adulthood. But there are comorbidities that make it hard, and you need somebody who really knows this. Dr. Allison Logan here does adult ADHD evaluations, and she's quite good at it. And what I mean by the comorbidities is that, let's take impulsivity. What mental health problems and diagnoses can cause problems with impulsivity? All sorts of things. And another controversial issue is that people like their stimulant meds. And so medication abuse is something you have to be mindful of with the population of adults. So let's talk about autism here. I want to save 10 minutes. It runs on a spectrum. It does. DSM-5 changed to recognize that in 2013. They dropped Asperger's disorder. They added social pragmatic communication disorder. We'll talk about the criteria for that in a second. It's 1.7 prevalence rate. It's two things: persistent deficits in social communication and social interaction. And here are some examples. The normal back and forth in social and emotional reciprocity, social approach, back and forth conversation, sharing your interests, sharing your emotions. Deficits in nonverbal communication. Kids with autism have a hard time often with gesturing, even gesturing. One of the things I do if I have a child in here, I have a 14-month-old coming in about a month, and I'll do a lot of pointing and modeling to see if I can get the child to gesture to things. It's an example of a nonverbal. Abnormalities in eye contact, body language, in an extreme case, lack of facial expression, lack of communication, deficits in maintaining and understanding relationships, not just social skill problems. One of the really important diagnostic things for autism, it's again, which came first, the chicken or the egg thing. What I say to parents is, if you have autism, you're going to have social skill problems. Just because you have social skill problems doesn't mean you have autism, which is why you have the second set of criteria too for autism, and which is why they pulled out the social pragmatic communication disorder. You have to have those unusual behaviors, restricted, narrow, repetitive patterns, manifested by at least a couple things in these areas. Examples are illustrative, not exhaustive. Stereotyped repetitive motor movements, not just if a parent says to you, oh yeah, my kid doesn't do well when I change things up, that doesn't automatically mean autism. Kids with autism have trouble changing things up, but if you have trouble changing things up, it becomes a question of degree. Insistence on sameness. As a student, I remember a case, I've heard this many times since, variants on this, but I remember a case stuck out in my head because the parents said, if we go a different way to school, we take 3 turns to school. If we have to go to the gas station, if we decide to go a different way for any reason and we turn at the wrong place, my child will scream and scream and scream and scream and be unconsolable and have tremendous difficulty, including for a long time afterwards. And that always stuck with me, and certainly I've seen that. Highly restricted, fixated interests that are abnormal in intensity or focus. And again, it's on a continuum, so you need somebody that knows how to make this diagnosis. It's an easier call if you have a kid that will watch a fan go around for 45 minutes and have a hard time breaking away from doing that because there's something visually fascinating, or a kid that engages in stereotypic behavior, self-stimulating behavior, and does it over and 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 over. But it runs on a continuum. You may have heard the term sensory integration disorder. Kids with autism have either hyper or hyporeactivity to sensory input, and other sorts of rigidities. Only want to eat macaroni and cheese for not just a day, but a week, 3 weeks, a month, 3 months, sort of thing, etc. Again, they've pulled out social pragmatic communication disorder into its own thing to differentiate it, to differentiate this group who have some deficits in communication, as we've discussed, is also the case with autism, but they don't have the other restricted, repetitive, stereotype sorts of behaviors. They have deficits in communication for social purposes, specifically. And the folks that did DSM felt that this was a subgroup that was common enough that we've got this now as a disorder. So it's one of the rule outs, I will say, and you can come back to these slides, save this. Feel free to email either the organizer, or feel free to email me here at On With Life too if you want me to send you a copy of my slides. Okay, let's keep going. We've discussed some of these things. You can have problems with attention too, very commonly. We've talked about a number of these things. Gesturing, eye contact. It can be extreme enough that I've heard mothers say that when their child, who had a more significant autism, was younger, they didn't even react to them. The bonding wasn't good. They didn't react to them like they were a person, more like an object. Understanding other people's feelings, talking about their own feelings. Some kids with autism do like physical contact, but they may want to do it only when they want to. And when you try to initiate, it's uncomfortable to them. They may, in some cases, be unaware, appear to be unaware when other people are talking to them, not responsive. They may be interested in people, but not know how to relate to them, interact with them. You get some repetition, echolalic repetition of words or phrases in an unusual way. If you have a child with autism and you go through these criteria, the parents know exactly what you're talking about. They don't engage in pretend games. They may repeat things over and over. Adaptation, we talked about sensory integration problems, or even sensory integration disorder. Some people think it's a specific disorder. Here's some of the interventions. Applied behavior analysis. All of the approaches, behavioral approaches, are designed to often one-to-one work with a kid to get their attention, to have them focus on you, can involve some very specific positive reinforcement, to the point that a therapist may use food reinforcers even, because you have to get a kid looking at you. There's different kinds of applied behavior analysis. You're trying to teach a child very fundamental skills that you take for granted: looking at people, responding, giving a verbal response. And these are some, I'm not going to go into detail on these things, but you can research these. These are different types of applied behavior analysis that the behavior analytic person knows. It's very stepwise, it's very concrete, it's shaping, it's sort of one step at a time to try and build in a very stepwise fashion, a skill that, again, we take very much for granted: interacting with other people, eye contact, responsiveness, using verbalizations. One of the things, I think maybe on another slide here, is that kids with autism will lose speech. It's a fascinating disorder. What is it? You go till 1 year old, 1.5 years old, 2 years old, and your speech seems to be coming along fine, and then you lose speech functioning a little bit, or a tremendous amount. Can certainly happen in autism, and we don't understand why. Here's another type of applied behavior analysis, and we've missed these things. Look these up as specific sorts of things if you have an interest in the different kinds of applied behavior analysis. Structured, social skills. I feel like I have a sense when I'm out there in the world and I see a parent interacting with a child and doing real specific social skills training. I'll look at him, that maybe that child has autism, or concerns about autism. because it's got to be that stepwise structured approach. Assistive technology can be tremendously helpful. Communication boards. Communication is a big difficulty often in autism. Runs on a continuum. You know, we used to use the term high functioning and low functioning autism. I don't really like those terms. Raise your hand if you want to be referred to as being low functioning. But it certainly runs on a continuum in terms of skills and abilities. There are kids with autism that are very bright in ways, and other kids have an intellectual disability as well. I'm going to keep going because I want to make sure I leave time for questions. Treatment and education of autistic and related communication handicapped children is a program that involves using occupational therapy. Occupational therapy can be really helpful with the sensory motor aspects of autism. Social skills training is critical, starting with the basics, real basics, and then speech therapy is really important. I don't. People ask me sometimes, you know, if there's a specific program that I endorse here in Iowa. I don't. There's a number of programs that are good programs out there, and you can research those. If you have questions, call me about a specific program. I'm glad to talk to you. There aren't any medicines that can cure autism or treat the core symptoms. There are medicines that can be helpful if one has autism with some of those associated comorbid sorts of problems. So if you have a high energy level, sometimes a medicine can help with that. Inability to focus, anxiety, depression, you know, psychotropic medicine, behavioral difficulties, self-injury. You can see some self-injury in autism. Seizures, obviously, there's seizure medicine. There isn't any medication for autism the way that there is for ADHD. Medicines for ADHD are like magic. It's easy for me with ease at this point in my career to talk to parents about the medicine issue for ADHD, including because, boy, when they work, they often work quickly. You don't need to make a lot of changes or dose changes. The side effect profile is not high. Make sure they're eating enough because, you know, it's why back in the 60s people took diet pills. And those were amphetamines, so you lose your appetite with those. We don't know what causes autism spectrum disorder. There are likely many causes for multiple types. Our developmental pediatrician in town, Dr. Nate Noble, says eventually we'll have many more names for many more disorders, including those that are on the autism spectrum disorder now. There's lots of genetic work being done. But at this point, I think it's appropriate to have the autism spectrum disorder concept out there. Genetics are important. Higher risk if you have a sibling with autism spectrum. Certain genetic and chromosomal conditions, Fragile X, tuberous sclerosis can have a greater chance. Likelihood of having autism spectrum disorder. Certain medications are known to increase the risk involved. And older parents are at more risk. You know, not inevitable, but these are risk factors. 4 times more common in boys than girls, occurs across racial, ethnic, and socioeconomic groups. There's a study out there right now, and if you have a family that's dealing with this, CDC, a lot of the material today, by the way, comes from the CDC website. I've used some of their material. They're currently working on one of the largest studies today, the study SEED, the study to explore early development. So they're looking at all sorts of risk factors and other things. So if you have a family that's interested in research, just interested in what they're doing, have them find out about this, and if they want to participate, I don't know the inclusion criteria for that, but check into it. It's a big study and a well-done study, it looks to me like. All right. Vaccines do not cause autism. The literature, in my opinion, is clear. Neither do vaccine ingredients. Talk to your physician about your own case, your child's case, and your own child's makeup and sensitivity to various substances. But vaccines and vaccine ingredients do not cause autism. There's a number of things you want to keep in mind. Selective mutism is a thing. You can, again, it's which came first, the chicken or the egg. You can have communication problems. That doesn't mean you have autism. If you have autism, you're going to have communication problems. We've covered some of this. So all of these, if you have schizophrenia, childhood schizophrenia, you can have unusual behaviors. You can have communication disturbance, but you need to be able, you're professional, that if you're doing this or you're having somebody do it for you, you need to be able to differentially diagnose these things from true autism. There's some more data for you. I'm going to move along a little quickly here. Look at this. It's fantastic. Fantastic. It's last year from the AAP. Terrific. Also struggling during the pandemic. Just this past Saturday, an article on autism. Some have a harder time with online learning. Some have an easier time, depending on the child. Thank you very much. I know that's a lot of material. I appreciate feedback. If there's a feedback, I will open it up to questions. If there's a feedback mechanism when we're all said and done here, then please provide feedback. I'd like to make this as good as I can, but I very much appreciate your having me. If you have any questions for me outside of the next 10 minutes, feel free to call me, or if you get my email, email me. And if you have a group that you want me to do either an online or now an in-service, an in-person in-service, I'm glad to consider that. Thank you very much. We'll open it up.
A couple questions. First one is, do ADHD kids commonly have a learning disability?
Not commonly. I don't know the percent. I'm going to say maybe 10%. I don't know that for sure. I haven't looked up the most recent data, but my clinical experience is that it's no more than 10%. I do a lot of these evaluations. I do lots of ADHD and autism evaluations. So it's more likely, 10 to 15%. It's more likely for sure. Now, having said that, I'll qualify and say that what I'm referring to there is a specific learning disorder, not just that you're a little behind in math, a little behind in reading, a little behind in writing, but that you're, a standard deviation to a standard deviation and a half in a discrepancy model comparing to your IQ before you will diagnose a learning disorder per se. If you're just a little bit behind in math, you don't have a learning disorder. You're a little behind in reading, you don't necessarily have dyslexia, which the more appropriate term is reading disorder. So having said that, if your brain's not organized in a typical fashion, while that figure of 10 to 15% may be true for the number of kids that have a specific learning disorder, there's lots of kids with ADHD, and you can imagine why, for a variety of reasons, that are behind. Not the least of which is their trouble with focusing, concentrating, paying attention, and sitting still. I love to get kids, the younger the better, because you fall behind, and there's lots of bad consequences academically, socially, psychologically, behaviorally, to falling behind and continuing to falling behind and being aware that you're falling behind and that you're treated differently for those reasons. So how much of that being behind somewhat is because your brain is organized in a different fashion, and how much of it is because you have an untreated, to that point, ADHD? That's a good question.
Okay, next question is, many psychologists, because of low reimbursements, will not see Medicaid or some other payers' patients. Do you see all comers?
We do not. I'll sound defensive in saying this, but it's true that when I first started here, my CEO and I went down to the state building and tried to talk about doing neuropsychological evaluations for a number of populations, folks with traumatic brain injury, and children with a variety of conditions. Because of the reimbursement rate issue, we were unsuccessful, at that time. And so without trying to defend myself more, we do not accept here at On With Life Medicaid and Medicare. Let me add at this point while I'm thinking about it, I'm willing to stick around past 1 o'clock, by the way, if IT you are as well. So there's my answer to that question.
Okay, one more question. If Asperger's disorder has been dropped, where does it fall now? And what about previously diagnosed people?
Good question. It falls at the, again, people use the term higher functioning. Kids who were previously identified with having Asperger's had some degree of unusual behavior. Their language skills tended to be better. But the better way, I think, and the way the DSM considers this, and I think this is valid myself, other people disagree with that, especially when DSM first changed. Lots of being upset about taking that diagnosis away when it had been assigned. Now, having said that, the response to that is, well, if you still qualify for a diagnosis of autism spectrum disorder, you still qualify for that diagnosis. So those kids are just on that spectrum where their IQ may be higher than some, their language skills may be higher than some. They may not show as much in the way of some of the restricted, repetitive, unusual sorts of behaviors. I don't say unusual in any pejorative sense, by the way. They are unusual things. And so that's the way it's considered. It's such a spectrum. Intellectually, cognitively, language-wise, even some of these behaviors, the sensory integration stuff. There's some kids that don't have much of that. Other kids have incredible difficulty with any or all these areas, which is why Dr. Noble in town, I think, has said, we'll be breaking this out further. I don't think Asperger's is ever going to come back myself as a specific diagnosis, but there will be other things. DSM, we're learning all the time. So here's my answer.
That is it for the questions. One comment. Thank you for the great presentation.
Well, that's kind. Thank you, everybody, very much for having me. Feel free to contact me with any questions. Thank you. If you happen to be one of those folks that has made a referral, thank you very much. I would have preferred to have done this in person, so I could have met some of you. But thank you, and on your end, sir, helping me. I'm sorry, I'm blanking on your name right now.
Tim.
Tim, thanks so much for your help as well. We'll sign off.
You're very welcome.
All right. Take care, guys.
Thanks. Have a great day.
Thanks, you guys too. Bye.